Hello, everyone, and welcome to today's Health and Wellness webinar, Produce Prescriptions, Blazing the Trail for Better Health. We're delighted to have two wonderful speakers today, Kurt Hager and Kathy Taylor. My name is Katie Calagero. I am the Director of Marketing and Communications for the Foundation for Fresh Produce, and it's my pleasure to be hosting all of you today. Thanks for taking the time. So, you may already be aware of the Have a Plant programs, but for those who aren't, these programs are committed to helping consumers live happier, healthier lives by boosting appeal for fruits and vegetables. And we do this by creating compelling content and distributing science-based, consumer-focused resources and food, nutrition, and health influencer engagement throughout our entire digital ecosystem. This includes our website, fruitsandveggies.org, as well as our social media channels. Our educational resources, including consumer insights, communication tools, can help you inspire lasting behavior change amongst the individuals you work with each and every day. These resources and our core messages are something you can really rally around as you're working with or educating consumers about the importance of having a plant every time you eat. We're all about consumption, and you all play a critical role in helping us achieve that goal, so thank you. Okay, so before we get started, there's a couple of housekeeping things I want to go through with you. All right, so the CPE activity application right now is pending with the Commission on Dietetic Registration for review and approval for 1 credit. Okay, so we'll get that certificate to you with a link after the webinar with the recording. So you can sit back, you can relax, you can take some notes, but you will definitely get these slides as well as the recording after the webinar is over. Okay, so what about questions? I want you to ask questions as we go. And to do that, you can go ahead and type your questions in the Q&A function at the bottom of the screen. So at any point, we don't want you to lose it. So type it in, and we'll take time at the end to go ahead and answer those questions. Okay, so now that you're aware on how to ask questions, and you know we're going to send you the slides, and you're going to get your certificate, and you're going to get credit, and it's all going to be great. Let's get into the nitty-gritty here of what we're about to talk about today. So first, I'd like to introduce Dr. Kurt Hager, an instructor of population and quantitative health systems at the UMass Chan Medical School. Next, Kathy Taylor, Director of Medical Nutrition Therapy at Grady Memorial Hospital in Atlanta, Georgia. She's been at Grady for 28 years and currently manages the dietitians at Grady, inpatient and outpatient. She's also over the WIC program, as well as a new component, the Food as Medicine program. We're super excited to hear from both of these experts today. Now I'm going to pass the baton over to our moderator, Ms. Stephanie Hodges. Stephanie is a public health dietitian and the founder of Nourished Principles. She's a consultant with IFPA and the Foundation for Fresh Produce and helps the organizations navigate opportunities to improve nutrition in federal programs and policies. So thank y'all for being here. I'm going to turn it over to Stephanie, and I'll see you at the end.
Thanks so much, Katie. Whether it is to address a nutrition-related chronic condition or improve food security and nutrition security, innovative approaches are being implemented to increase fruit and vegetable consumption. One approach to doing this is known as produce prescriptions. They aim to improve healthcare outcomes, optimize medical spending, and increase patient engagement and satisfaction. And we have a really great video to share. We'll pop that in the chat around produce prescriptions if this is the first time you're hearing about them, or maybe you're well aware. It's a really good, just informational video overview. You can feel free to use this in your practice or share it with others as well. In this webinar, we'll define a produce prescription program as a medical treatment or preventive service, identify best practices, highlight research, and provide firsthand experience on how a health system implements a produce prescription program. Kurt, I will go ahead and turn it over to you to begin.
Wonderful. Thanks, Stephanie. So I want to first just dive into a little background on the burden of diet-related illness in the U.S., how it intersects with food insecurity, the recent COVID-19 pandemic, and just give a little background on why health systems are really increasingly interested in offering produce prescriptions to their patient population. I'll then review some of the most recent studies on produce prescriptions and analyze the impacts on health outcomes, and talk a little bit about the emerging policy pathways through which Medicaid programs in some states are beginning to pay for produce prescription programs for their members. So to start on this first slide, in the United States, we have an incredible burden of diet-related illness in the United States. So of the over 700,000 annual deaths from cardiovascular disease in the US, over half of those are directly attributable to suboptimal diet. So this is a study that I really like because it aims to outline which aspects and key food groups are responsible for this excess burden. And what you can see here in the green are the number of deaths in the US each year from eating too few of healthy foods. And in the red, number of deaths attributable each year to eating too many unhealthy foods. And I think a key takeaway from this figure is we actually stand to prevent more loss of life by increasing the consumption of healthy foods than decreasing the consumption of unhealthy foods. And you can see here that fruits and vegetables, there's a tremendous opportunity to save over 100,000 lives a year by increasing consumption of fruits and vegetables. So I think this is something important to keep in mind when we think about what health systems can do. So if we want to go to the next slide. Unfortunately, the pre-existing burden of diet-related illness in the United States was compounded by the COVID-19 pandemic. And essentially, we had a fast-moving infectious disease over a pre-existing kind of slow pandemic of diet-related chronic illness. So cardiovascular diseases and COVID-19 are ultimately both vascular inflammatory illnesses, and they can exacerbate one another. So for example, this study found that had the United States had a metabolically healthy population at baseline, nearly 2/3 of COVID-19 hospitalizations could have been avoided. And on the flip side, we also see emerging research that shows that a severe COVID-19 infection can make managing diet-related illnesses like diabetes more complicated moving forward. We can go to the next slide. And then the other unfortunate layer of complexity on these issues is the issue of food insecurity. So either worrying about not having enough food to live an active and healthy lifestyle, or running out of food before a family has money to buy more. This is ultimately an acute symptom of poverty. And unfortunately, it is also in many ways an embodiment of the injustices in our society and our economy. We can see here, for example, that across all years, there are large disparities by race and ethnicity in experiencing food insecurity in the United States. We can go to the next slide. And food insecurity has a really significant impact on health outcomes. So a lot of studies have shown that when households are short on finances, they're making very rational day-to-day decisions to prioritize whatever need is most urgent in that moment. So this means foregoing medical care or medication use, choosing between food and other basic needs like rent or utility. And this next one, I think really stands out to me. It's choosing to consume low-cost, energy-dense, often less healthy foods because they're cheaper, and if a family doesn't have enough money to afford the healthy foods. And I think this is really important if we're thinking about when we're communicating with patients, and if they're just getting advice to say, hey, you just need to eat healthier, and they just are struggling to afford those healthy foods, that could create, I think, distrust between a patient and their care team. And I think this is a really important insight into how produce prescriptions could help not only improve patient outcomes, but give clinicians, dietitians, and patients a really useful tool to address their needs and meet them where they're at. So if we go to the next slide, I just want to highlight a really eloquent example of how food insecurity can impact diet-related illness. So what we have here are on this slide is on the bottom, it's the day of the month. And on the y-axis, these are hospitalizations for hypoglycemia among individuals with diabetes. So this is a very dangerous condition where very low blood sugars. This can often occur with someone who's taking insulin and not getting enough food to eat. And what we see here, this line on top in the red that increases towards the end of the month, this is hospitalizations for hypoglycemia among low-income households. But we can see that episodes for hypoglycemia don't increase at the end of the month for high-income households. And what this suggests is that there's a cyclical process in which when at the end of the month, when households are short on food and finances, or if they've already used all their SNAP benefits, they're at a much greater risk of experiencing an episode of hypoglycemia. So I think this shows just really clearly how food insecurity can make managing diet-related chronic illness much more challenging. And if we go to the next slide, keeping this example in mind, and there are many other ways in which food insecurity can impact health, it's not surprising that many studies have shown that food insecure households spend almost 50% more, for example, on medical care in a year. So with this background, what can we do about this? So fortunately, there's an emerging movement to have clinicians and health systems think about food insecurity and nutrition insecurity and providing certain patients with tools and resources to access the healthy foods that they need to optimize their health and well-being. So I want to provide a quick overview on several studies that have been recently published that kind of give the state of the evidence on produce prescriptions specifically. So these are programs that are offering either, usually the older programs offer paper vouchers in which people could redeem them for free fruits and vegetables at retailers or farmers markets. More often now, and I think almost exclusively moving forward, these programs will likely be implemented using electronic cards, which participants can use at a retail grocery store. It makes operating these programs really administratively efficient, but there's still some variation in kind of what that looks from program to program. So this first study that I'll discuss was a study that I led in partnership with a team at Tufts University and at Wholesome Wave. We pooled data from 22 programs across 12 US states that are operated by Wholesome Wave. And this still remains the largest produce prescription study to date. So we had nearly 2,000 children and over 2,000 adults included. So if we go to the next slide. A little bit about these programs. They provided on average for the programs that enrolled adult participants, about $45 per month. For programs that targeted children, this was often a bit more. The median was $115 per month. And again, this was a mix of electronic cards or vouchers in which participants could redeem for free fruits and vegetables at retail grocery and farmers markets. And these programs are relatively long. So on average, it was 6 months, but it was 4 months was the shortest and up to 10 months for the longest one. If we go to the next, just a little bit about the population that was enrolled in these. You can see in the adult population, this was predominantly female, large percentage identified as non-Hispanic Black. For the child population, the was predominantly a Hispanic population. And if you look at enrollment in SNAP, WIC, and insurance, you can see here through Medicaid, indications of many households with low income. And for the next slide, these are this kind of the starting baseline values. These are all our outcomes of interest. So all the participants in our study were recruited because they were referred from a health system that had a relationship with Wholesome Wave, and they had either overweight or obesity or diabetes or hypertension. So this was the population that we were focused on. But you can see really high rates of food insecurity, and among the starting baseline values in the adult population for hemoglobin A1C and blood pressure and BMI, we can see that on average, people with diabetes are having uncontrolled diabetes. People with hypertension have very elevated blood pressure as well. So gives you a sense of the population that was enrolled. If we go to the next slide, these are our outcomes. So we looked at chain measurements before and after participating in the program. So these are for adults. We can see a significant improvement in hemoglobin A1C by about 0.3 percentage points, an improvement in weight as well among those with overweight and obesity, and a pretty large improvement in blood pressure among those with hypertension. So these results were both statistically significant, but also clinically meaningful. If these were to be maintained long-term, these could have a really real impact on overall health and well-being among this population. I'll say that we also saw improvements in food insecurity, self-reported health status, and an increase in consumption of fruits and vegetables. For children, we did not see an improvement in weight among children with overweight and obesity. However, childhood obesity is just a notoriously challenging metric to move. And to me personally, the households with children, we still saw food insecurity cut in half. We saw improved self-reported health status. And I think we can all agree that if food insecurity is improving, if kids are eating more fruits and vegetables when they're participating in this program, that alone, I would hope many of us would consider as a success as well. So the one drawback from this analysis is essentially a pooled analysis of many programs across the country, but we didn't have access to comparison groups. So it is possible that these results could have occurred due to other changes in medication, other factors outside of the produce prescription program. So we can't say for certain these are causal, but these are really encouraging results that I think offer strong rationale to invest in future randomized trials. So if we go to the next slide, I'll talk about another study that was essentially part of this first study. So we had a strong relationship with 2 of the sites of those 22 that were included in the previous study. And due to the stronger relationship with Hartford Healthcare, we were able to get data on comparison members. So really similar patients who didn't participate in the produce prescription program. This program exclusively enrolled individuals with diabetes. And our primary outcome was hemoglobin A1C, so an important marker of average blood glucose levels. And for those interested, I won't go in depth on the details, but I'll just say this was a quasi-experimental study, and we used a propensity score weighting approach to essentially compare similar patients who didn't receive the services to those who did receive the services to the produce prescription program. If you go to the next slide, a little bit about this program. It provided $60 a month per household for 6 months. But I want to highlight the fact that this program duration started in November 2019 and ended in October 2020. So all participants their participation coincided with the large disruptions of the early COVID-19 pandemic. If we can think back to those early shutdowns, people were told, not to come into the clinic unless they desperately needed care. Grocery stores had food shortages. This was a really, really disruptive time. If you go to the next slide, I will highlight our findings from this do contrast some with the previous study. This shows change in hemoglobin A1C over time. So 0 is the month of enrollment. This was a 6-month program, but we continue to look at outcomes up to 9 months after. The blue lines are the treatment group. So those who receive produce prescriptions, the red are our control group. And the error bars show, since they overlap at nearly every month, that there was no significant difference in hemoglobin A1C levels between the treatment and the control group in this particular program. So if we go to the next slide, kind of what do we make of this? So one, I do just want to highlight that there were, again, these large disruptions in clinical care and in the economy. Patients would have had fewer touch points with the care teams, large disruptions in work, income, and childcare when schools were closed. Stimulus aid was released that summer, so this included large increases in nutrition assistance and things like SNAP and WIC, stimulus checks, etc. So those could have really impacted the successfulness of the program. But at the same time, I think it's important to consider design factors. So this program did not give more money for larger household sizes, which is what SNAP and WIC do. There wasn't a nutrition education component to this specific program. So these might be key design factors that might improve the overall effectiveness. And it's also possible that there could be some publication bias or regression to the mean in previous studies. This describes a phenomenon that if someone is sick at a certain time, when you enroll them in the study, just by random chance, they might be better 6 months later. So I just want to throw this out there to say that I think future research will really focus on which programmatic components specifically are most likely to guarantee success of these programs. And they may not work in every context, but it's also important to consider that many studies emerging right now that are being published on produce prescriptions and other foods and medicine programs occurred during the COVID-19 pandemic. So I think there's just something important for us to consider. as the literature keeps coming out in the next year or two. So I'll just provide one or two more studies here. This is the strongest evidence to date. This hasn't been published in a peer-reviewed journal, but this was a presentation at a conference last fall. This was a well-done randomized controlled trial, enrolled people with type 2 diabetes. This was a 6-month produce prescription program. This program shifted to delivering food during the COVID-19 pandemic, which I think is a really key point. These were home delivered. And again, hemoglobin A1C was the main outcome measurement. And in this randomized trial, if you advance one more, we did see actually a really similar effect size. So the first study I presented, about a point, almost a 0.4 percentage point improvement in hemoglobin A1C. So really encouraging results. And I would point to this as the strongest evidence yet that produce prescriptions can have a really meaningful impact on health outcomes, especially for diabetes management. And the final study I want to share with you all was a modeling study that I also helped contribute to. Again, focusing on US adults with diabetes. So how these modeling studies work is you draw a nationally representative sample from a nationally representative surveys. So this we used NHANES. And you kind of look at the baseline dietary intake of the population and estimate how it might change through a produce prescription program. And then there are validated models that run simulations to estimate the change in cardiovascular disease risk. So things like if you increase your fruit and vegetable consumption in 30, 5, 10, even up to 30 years, what is the adjusted risk with this new dietary change? Are you experiencing something like a heart attack or stroke? So that's essentially kind of the background of how this study was conducted. But the key findings is that produce prescriptions, in terms of preventing or saving quality adjusted life years, are as cost effective and even slightly more cost effective than commonly prescribed medications like drug treatment for hypertension or use of statins. So I think this is encouraging to show that produce prescriptions can be likely a really key a complementary part of clinical care that are highly cost effective as compared to treatments that are already being used. And I think it's important that things like produce prescriptions can be used alongside other medications. Okay, so I'll stop there for kind of an overview of the research and the evidence today, and just finish really quick on a couple points on the sustainability of these programs and who ultimately pays for these. So traditionally, most programs have been supported by small community-based organizations, and many of these organizations run on grants, donations. For example, the first study that I presented with Wholesome Wave, all of those programs were funded by foundations. All of those programs were short-term, so after that was 6 months, the programs ended, they disappeared. There wasn't an opportunity for participants to continue, nor was there an opportunity for new patients who might benefit to enroll. I think this is something for us to keep in mind. If we go to the next slide, policymakers at the state and federal level, therefore, are looking at ways in which health insurance, and specifically programs like Medicare and Medicaid, might be able to begin covering some of these. So in the White House Historic White House Conference of 2022. This was the second ever White House Conference on Hunger, Nutrition, and Health in U.S. history. The first occurred over 50 years ago in the Nixon administration, and really big changes emerged from that. So things like the nationwide expansion of school meals, the creation of SNAP, then known as the food stamp program, and the creation of WIC as well. So the report from this most recent White House conference identified increasing Medicare and Medicaid coverage as a key policy priority. But currently, it's really important to note that these are not covered benefits in either program for all enrollees. However, there are a couple exceptions here and there, and I'll touch on one of those and then pass it off to the next presenter. So an emerging policy pathway is something that's known to cover things like produce prescriptions, is something that's known as Section 1115 waivers. So at a high level, what these waivers do is they allow states who operate Medicaid, which is the health insurance program for people with low income or who have a disability. They allow states to get a waiver from the federal government to pilot something new within their state Medicaid program that's not allowed under federal law. But they submit an application and they have to make a convincing argument that what they want to do is likely to improve health outcomes without adding total cost to the program. And then the federal government can approve a waiver for up to 5 years. So several US states are currently using these 1115 waivers to pay directly for produce prescription programs for specific qualifying members in their Medicaid program. So if we go to the next slide, I'll show here is a figure from a recently published study in Health Affairs that looked at states' use of 1115 waivers to advance nutrition priorities. So as you can see in the orange, there's a handful of states that are using 1115 waivers to advance nutrition education coverage. Wouldn't be allowed otherwise. And then in the blue on the bottom here are kind of this teal, we see states that are using waivers to actually pay for healthy food for their members. So you can see that Massachusetts, Oregon, and North Carolina had waivers approved kind of the first round, but then just look at all this in the last 2 years, a handful of states have gotten waivers approved to conduct similar programs. And so now there are 7 states with pending or approved waivers to cover produce prescription programs. And my last slide here, for anyone interested to see what these programs look like in practice, I believe these slides will be shared later. You can click this link. This is a comprehensive list of each health system in Massachusetts that's operating a program in the state and for which specific patient populations. And if any of you are practicing in Massachusetts, you might even be able to enroll your patients in these if you're working within a Medicaid accountable care organization in the state. So with that, I'll pass it off to our next presenter.
Perfect, thank you. That was great information. So I wanted to talk to everyone about our program here at Grady. We know poor diet is the #1 risk factor for death globally. It has now surpassed tobacco smoking, surprisingly. So we can say for sure that the #1 cause of death in America is the standard American diet, which is sad. Some of the barriers to healthy eating is food access, nutrition knowledge, culinary skills, motivation, and support. So here at Grady, we're trying to take a different approach to helping our patients overcome the barrier of food insecurity by doing what we call food as medicine through a produce prescription program. And this is done in partnership with our Atlanta Community Food Bank partners and Open Hand in a space that used to be a fast food establishment here on campus. So that's been for our nutrition professionals, just a positive that came out of this program. So it is an innovative partnership that addresses food insecurity and chronic disease. And we're focusing on uncontrolled hypertension and uncontrolled diabetes. And so our goal is to drive better health outcomes for those 2 disease states as a hospital organization. And we strive to improve access to healthy food among Grady patients and employees. So when we looked at the scope of this issue for our organization, food insecurity at Grady is nearly 4 times higher than the rest of Atlanta. When we did surveys, the surveys indicated that about 50% of our patients, both inpatient and outpatient, showed food insecurity, and that's 140,000 patients in general. So that's our partnership, and that's why we're working on this program. Next slide. So in our prescription program, we're trying to address chronic disease management, basically. And so as patients come into the hospital and see their primary care physicians, they are screened for food insecurity by our certified medical assistants. They ask them the 2 hunger vital sign questions, which are, within the past 12 months, we were worried whether our food would run out before we got money to buy more. And within the past 12 months, the food we bought just didn't last, and we didn't have enough money to get more. And so if they answered often true or sometimes true to those questions, that would indicate positive food insecurity. And in our electronic health record, we use Epic. We have built the program to search the system for an A1C above 9 and a blood pressure above 140/90. And if that's the case with that certain patient, then a best practice advisory would fire for that patient. And the screener would then work through that BPA to send a referral to the food pharmacy as well as the nutrition department. Excuse me. So once that referral is in place, the patient is able to walk into that clinic, and we call it a clinic because we don't want the stigma of it being like a pantry or just a food handout. It really is a medical clinic and a way for us to address managing these patients' disease states. And so we've set the program up in 3-month episodes. And so for a patient, once the patient's enrolled, if they meet these requirements, they can continue in the program for up to a year. So those requirements are that they need to pick up produce at the food pharmacy every 2 weeks. So they're allowed 6 times in 3 months and with a minimum of 4 times. And again, this is free to them, no copay. They need to see their dietitian at least once a month for the 3 months, a minimum of 2 times. This is really the only portion of that of the program where there may be a copay that applies. There are also virtual options for patients. So if they don't have the transportation to get in, we can manage that as well to get their appointments in place. We also have a teaching kitchen and require patients to have at least 1 cooking class in that 3-month period. And again, this is in person, no copay. And then we'd like for them to circle back to their physician so that they, check their medications, check their labs, see if they're moving in the right direction, and get encouragement from that primary care physician to continue in the program. And so as they get those referrals, we do ask that whoever is sending those patients to the program that they use the talking points that we have in the system, and that is to indicate to the patient that this is part of your diabetes and hypertension management, part of your care plan, and this is a program that will provide you with the tools to improve your health. And we also measure biometrics, of course, while they're in the program. We monitor their weight, their BMI, their waist circumference, blood pressure, A1C, their food insecurity status. We do a little more in-depth questionnaire. I think it's the 6-question questionnaire for that. We monitor their quality of life, healthcare utilization, their PCP visits, hospital admissions, ED visits, and costs, and so forth. Next slide. Now this is our teaching kitchen. Classes are usually 1.5 hours to 2 hours long for each session. We cover life skills education, such as budgeting, meal planning, safety in the kitchen. And of course, we cover diabetes education, hypertension education. And it really is a place of fellowship and community for our patients. We see patients coming here. I don't know if you recall maybe your first day of lab when you were in college and how nervous and anxious you were. That's the feel that many of our patients come in with because they've never been really given the opportunity to do anything like this. So they come in a little anxious. Our teaching kitchen manager, Donna Blissett, really works with them to get everybody at ease. She also provides them with a report card that has on there their A1C levels, their cholesterol, LDL, their weight, their BMI, all of these numbers every time they come in, so they become more accustomed to understanding their own health, and that gives them the opportunity to have that discussion with their physician in a way that everybody is able to communicate. And it's been so interesting to see our patients really understand and learn what an A1C is and be able to discuss that openly. We opened in August of 2020, right in the midst of a pandemic. But prior to opening, our plan was that patients would be in groups cooking at these stations at the counters. And then the pandemic happened, so we pivoted. Every patient now does their own, has their own cooking station, does their own food, seasons it the way they want to. And so it has become one of the best parts of probably our program, that pivot. So I think it was one of our best options. It has limited the number of patients we have at one time in these classes. We do 10 to 12 patients at a time, but it really has improved our education piece for our patients. We utilize the foods that's being given out in the food pharmacy for these classes, so that they learn and understand and taste the foods that they're going to be taking home. Many of our patients have never tried zucchini or butternut squash, none of these things. So they are a little hesitant, but when our teaching kitchen manager and our team in the kitchen shows them how to cook it and have them, season it the way they like it, they end up really looking forward to getting that produce in their prescription when they go home. Another thing we've done for our teaching kitchen, or in our teaching kitchen, is a culinary medicine program for our Emory and Morehouse physicians that are here on campus. As many of the RDs know, many of our physicians don't get any nutrition education in school. So we've taken an opportunity to do that. I've developed the didactic program of the culinary medicine program, and Donna Blissett has developed the cooking class portion of it. So I go through information, 10 nutrition concepts every physician should know, blood pressure 101, nutrition and cancer, numerous topics. And then after the topic, they come together and cook a plant-based meal together. So it has been very eye-opening and so appreciative of our medicine team to get that information and have that interaction. And you'll see we're working off of a pretty small team. We have a teaching kitchen manager, as you see here, that manages all of our cooking classes and students. We partner with Georgia State to have interns rotate through our program. We have a food pharmacy manager that I'll introduce you to on the next slide, but we also have a patient navigator that enrolls and schedules all of our patients for classes, ships coordinate transportation. We have a food as medicine tech that basically helps hold up all of these other positions, and a food as medicine volunteer coordinator that helps manage our Hands on Atlanta portion, or Hands on Atlanta site, to get volunteers in for all of our events. And we could not do it without our volunteers. So that is a huge piece of our program because, as Kurt says, we are totally donor and grant funded at this point. So next slide. So this is our food pharmacy and our waiting area for the food pharmacy. And this is our food pharmacy manager, Jasmine Blacks. I'm really proud of our whole team. We could not do this without this team and how dedicated they are and passionate about this program. Our food pharmacy is open Tuesday through Saturday with some extra time on Thursday evening for those who work, a half day on Saturday again for those who work and need the off schedule. We are a fully plant-based program. We partner with the Atlanta Community Food Bank to provide a great variety of produce, great quality of produce. We continually get responses back on our surveys of how much our patients really appreciate the food that's being brought in. For example, this week we got cantaloupe, green beans, strawberries. They're really just enjoying so many fruits and vegetables that they've never had an opportunity to get before. And so in our food pharmacy, a patient for a dose response, we make sure that every patient takes home at least 20 pounds of produce and 4 pounds of dry goods for every family of 4. And if there's more than 4 in the family, we provide them with double that amount. So it really does help offset the cost of the food that the patients are used to buying, or actually not used to buying. So next slide. So as I said, we opened in August of 2020. We've had 2,282 patients enrolled at this point. We usually have about 500 active patients at a time. We've had, at this point, 271 graduates of the program, and it's a pretty stringent program. And so to get that many graduates is pretty good. We want to see more of those, so we're continuing to work with those patients to get them through the program. 20% of them have children. Almost half of them have older adults in their household. We've distributed out of our food pharmacy over 15,000 pounds of food, or over 420,000 pounds of food, with 15,000 pharmacy visits. We've had almost 600 cooking classes and 3,000 patient visits to our kitchen. So this program doesn't only impact the patient, it is impacting the families and the community around us, which is really what we as a department really wanted to do. We want to see these changes happening for all of our neighbors here in the downtown Atlanta area. And if you look here at some of the impact statements from our patients in regards to chronic disease, one said that since I started this program 6 months ago, my A1C went from 16 to 5. And that's a statement that a lot of our patients are making. And we know that is changing the lives of our patients and really saving lives. When it comes to lifestyle changes, a patient said, before I started, I was on 3 different blood pressure medicines. At my recent visit, my doctor took me off 2. This program is great. It's given me the nutrition education and cooking skills I need to change my lifestyle and get healthier. And I know as a nutrition professional, we really want to see that kind of response. And I don't think, I think it's been even surprising to my staff how well the program has done for so many patients. We've even had patients on dialysis 3 days out of the week be in the program. And I know one has actually come off of dialysis to just 1 day a week, which, you know, quality of life with that is just amazing. And then when it comes to food security, the Foods Medicine program is great because once I pick up my produce, I know that when I go to the grocery store, I will not need to purchase as much food. So this is, again, affecting their monetary budgets so that they are able to make it to their appointments. They're able to put that money in other places. So we're taking that burden off of them. Next slide. Okay, just to continue with the impact, we have shown, of course, improved food security of those living with very low food security. There was a 12% decrease in food insecurity. We had improved perceived health. So the patients coming through the program indicated that they felt better, 3 fewer days of poor physical health during the month. And there was also shown to have improved physical health. So we showed a 2.4% decrease in A1C for those who graduated with uncontrolled diabetes. And we had a 1.3% decrease in patients' A1C for those who graduated without uncontrolled diabetes. So these are major milestones for our patients. And I can't even tell you how appreciative they've been that this has really changed the trajectory of their life. And those who graduate with those big advancements, they don't want to leave. And so I'll tell you about one of our expansions of our program at the end. So next slide. So this is one of our success stories. Ms. Rivera graduated in 2021. She came in with an A1C of 15.2. When she graduated the program, her A1C was 6.7. And she says, I didn't know how to eat, but now instead of feeling weak and craving unhealthy foods, I have more energy than ever before, and I know how to use vegetables in all my meals. So next slide. So again, this is a program that's easily accessible as we're located just right outside the main doors of Brady. As you can see this little map here on this handout. We provide this handout to our patient as they get a referral so they know where to go. They know our hours, they know what the program is about. And we also indicate to the team to definitely talk about those talking points with the patient so they understand that this is not just a food program, but it really is a part of their health care. Okay, next slide. We did see barriers. Of course, we're looking at that. In 2022, we found that about half of our patients didn't re-enroll due to competing priorities. So we tried to do phone interviews with those patients to see what those barriers were. And 44% of them showed that a lack of transportation was a problem. 24% said the time commitment was a barrier. 16% said the caregiver responsibilities were a problem. Many of our patients are taking care of other folks in their household, and so time with that is a problem. 12% had physical challenges, of course, and then 4% said their work hours. So we really tried to work on that transportation issue and partnered with one of our Georgia State assistant professors in the Department of Urban Studies Institute, Dr. Faye Lee, that included us in one of her studies to provide some transportation opportunities for our patients. And that is just ending. And so recently we have partnered with United Healthcare to provide our patients with some common courtesy Lyft rides. And so we work our patients through an algorithm to see, what other opportunities they can look into for the transportation opportunities. And so we have really worked hard on that to make that not a barrier. Next slide. As a part of the program, we also have a food bank member in our facility every Wednesday for a full day to sign folks up for SNAP who cannot be in food as medicine if they're not eligible or meet the criteria. And so that has been very beneficial. We also have those in our neighborhood clinics as a part of the program. Next slide. And another part of our program is our fresh food carts, what we call fresh food carts. And that's basically our neighborhood mobile food distribution. We have been providing food to our patients at these neighborhood clinics, Ace and Yancey, Brookhaven, and Ponce, since before the pandemic. And we have distributed 900,000 pounds of produce to over 32,000 of our patients. And we get compliments all the time from our teams at these clinics and our patients indicating that really this has been such a blessing to them and their families to be able to continue to eat healthy since the pandemic and beyond. So very proud of that. And just to let you know what our expansion is, we are working with our food bank to have a shopping experience for those patients who do not meet the criteria for our food as medicine program. So they will soon be able to come into our clinic and be able to sign up through the food bank for the produce as a shopping experience, and we'll be able to include those other patients at this point. So very excited about that expansion. At that point, I will hand it back over to the moderator.
Thank you so much to both Kurt and Kathy for an incredibly informative presentation. I also want to recognize we've had a really engaging chat. So thanks so much for everyone for your attentiveness and your passion around this topic. It seems like there are a lot of folks that are operating these sorts of programs or interested. So just really excited to hear about the opportunity for produce prescription and just kind of the general food as medicine movement. We've been getting a lot of really great questions along the way. If you haven't already done so, please type these into the Q&A. Unfortunately, we probably will not have time to get to all of them, but let me go ahead and kick off a few for our presenters today. Our first one, I'm actually going to send this over to Kurt because this was a specific question from your presentation. It was one of your first few slides, the data and research around the 51,000 deaths. Could you speak a little bit more to how that data was collected and maybe the methods of that research? The question was just, how was that determined? It seems like a really big jump to say that those deaths were caused solely by eating too much sugar. So if you could shed maybe a little bit of light around that figure from earlier on in your presentation.
Yeah, fair enough. So this is a very good question. To answer this appropriately, I'd probably need a half hour because this is a very detailed study, but let me do my best to give you a 1 to 2 minute answer. So this was what's called a comparative risk assessment study. And basically there's several steps. So the first step is you combine the effects from every study for those food groups that were listed that looked at consumption of those food groups with development, ultimately, usually years down the line, of things like heart attack or stroke. Then you combine all those effect sizes to get an estimate, for example, for how each additional serving of fruit and vegetable per day decreases your risk of heart attack and stroke. And then same for things like sugar. For each additional serving of sugar per day, how does that increase your risk of heart attack and stroke? Then so you've combined like all the studies ever done. You look at those, you combine their effect sizes, so you get the best estimate of the association between diet and mortality from cardiovascular disease. Then you use a nationally representative survey. So this, I believe they used NHANES for this, in which you have data on thousands of people that are representative of the larger US population on what their diet is. And then you compare that to the ideal diet based on what you see in the literature that would result in essentially zero, a hypothetical like zero deaths from heart attack or stroke attributable to diet based on like the ideal healthy optimal levels of each consumption. And then you compare that to the actual observed consumption in the US population. And you run basically a simulation to estimate for each death, say from a heart attack, what percentage is attributable for that death for like eating too few healthy foods or too many unhealthy foods. Then you sum those fractions for each death across all people in the study. So for example, let's say 50,000 deaths that you mentioned, it might not actually be like literally only 50,000 people from only sugar. It might even be like 300,000 people. But it's like a proportion of that death might be attributable to eating too much sugar, and then you sum that, and that's ultimately the value you get. So that was my best, the quick 2-minute explanation of how that study was done.
Thanks, Kurt. And maybe we can link to that study when we're sending out any follow-ups, and so that person can kind of dive in a little bit more to that. So thank you for that. Next question I will pose to both of our presenters. Kathy, if you'd like to go first, but it is around kind of produce prescriptions. I know you mentioned, Kathy, for a family of 4. And so the question was around, is the produce prescription, the program, the benefit, particularly the food component, is that for an individual or a family? And so Kathy, maybe you can talk a little bit about for your program, and then Kurt, maybe in your review of the literature and the research you have done, if you've seen both and you just want to shed a little bit of light on that.
Sure. So you're asking about, we're actually working off of food bank guidelines in terms of household size. So we are working, because we tend to report some of our information over to the food bank in terms of our usage and household size. So that's how we came to the 4 and meeting, the needs of that group. But you were asking about single individuals?
Yeah, so just how is your program designed? Is it really providing that benefit just to that one individual who maybe was referred, or is it really focused on kind of the family unit?
Yeah, it really was to deal with food insecurity for the family unit. And that's why we provide, if you've ever seen 20 pounds of produce and 4 pounds of dry goods, it's a lot. And, we kind of wondered if it would be too much for some of our patients. And so we actually did some surveys to see, are we providing you too much or too little? And the majority of our patients, 88% said, it was just right. It was the amount was just right. So we feel like we kind of hit our sweet spot. Of course, there's always a few that want a little more and a few that want a little less, but I think we did pretty well with the number.
That's great. Kurt, do you want to maybe speak a little bit to the literature and the research and what that's kind of saying in terms of individual versus household?
Sure. Well, I should say that there's not strong evidence from studies. There's no study that has tested this empirically where like half the people are only going to get, a set amount, and then the other half of people will get more money for each additional household member. But common sense clearly states that larger households should get more benefits. And I think it's just, we know that food will be shared within the household Let's think too, for example, let's say there's parents with diabetes and they have kids in the household. Let's say the health system is saying, we want you, the parent with diabetes, to improve your fruit and vegetable intake, but if their food is running short in the household, we know those parents are going to give the food to their kids and almost all the time. And so I think it's important for health systems to recognize that these, even if they're trying to target a particular patient, these ultimately are household level interventions. Interestingly, within the Massachusetts Medicaid program, in the first iteration of the program, organizations could only give food for the targeted individual. There was a lot of pushback from community-based organizations and advocacy groups in Massachusetts. In the second iteration of the program, CMS did give permission to provide more food for larger households, but only for select referrals. So it was for high-risk pregnancy referrals. They could give more food for larger households and feed the entire household. And then for pediatric referrals. So if the target patient was a child, they could get food for the whole household. So there's some movement to acknowledge this. But interestingly, let's say it was a parent who was referred, but they have kids in their household, because the target patient was a parent, they wouldn't be able to get additional food for the whole household. So that's just a kind of an example of what the policy looks like within a Medicaid space at the moment.
Thanks so much for that. One question that came up was around the selection of the produce. And Kathy, maybe if you could speak a little bit in your program, is there an element of client choice, or how do you kind of incorporate maybe client preferences, but then also if there are dietary restrictions and also cultural and traditional preferences, and how do you incorporate that into your program?
That's a great question. And it's something we kind of worked through from the beginning. We work with our food bank partners, and we get deliveries of produce weekly at this point. And it was a process to work through quantity, quality, because again, nobody else was doing this at the time that we started this. So my goal was to really make sure that we had a variety of produce, that we incorporated the patient's requests into that variety. For example, we live here in Atlanta. We have a lot of Southerners. Many of our patients love collard greens. They like leafy green vegetables. So we weren't getting those in the beginning. So we requested those and started getting those kind of cultural foods that our patients really enjoyed. But we also wanted to introduce new foods to them as well, that they had never had before. Zucchini, things that many people wouldn't really think that was so new and exciting, but they had never tried zucchini, eggplant, those kind of things. So we are introducing new foods, maintaining some of the cultural foods, along with ensuring variety, quality, and increased, color into their diet. Berries, fruits, and those kind of things as well. So it was a process. And so when it comes to client choice, we, of course, we're listening to our patients, but again, we want them to try things and encourage them to try things and not just refuse it. So that's something that is talked about in our cooking class. If you've never tried it, you got to try it. It's just like kids, everybody has to try this at least once. So yeah, that's kind of how we addressed it and are still working through it. And as we are opening up our shopping area for the patients, they are getting to not only get their prescription, but to maybe go in and shop for other foods that may be different as well. So it's really, I think, meeting all the needs of the patient at that point.
Great. So I'm going to try to fit in just one more question before we close out. And so we had a couple of people talk about, I'd love to get something started like this. Either I'm a farmer or I'm working in a community organization. So maybe both Kathy and Kurt, for the folks on the line, if they're interested in starting a program like this or getting involved, if you have any words of wisdom about approaching a health system or potentially a funder, kind of what would you say to our participants today who may be interested in trying to get involved in this sort of program?
Kathy, you might, I mean, you're in the weeds operating this is the program, so I'll let you take this, at least to start.
Okay, we started small. We started, a couple of our physicians did the surveys on the inpatient and outpatient side and saw that food insecurity level, and took that to our administration. And so they started a really small program with Wholesome Way Georgia and Open Hand, and then wanted to expand that. And that's when it came to my department. So I put it into 3 to 5 of our clinics at the time, got great results with a 6-month program. And I think starting small and getting good results from those programs is key. So again, we partnered with Wholesome Way Georgia, Open Hand, with a 6-month program of monthly cooking classes, monthly nutrition classes, and food prescriptions for the patients every week. And they would go to MARTA markets here in town to pick up produce every week. And that's how we got started. And so because we had great results, our administration didn't renew the fast food restaurants certificate. And so they utilized that space to renovate for us for this program. And so that's how we got started.
Oh, that's excellent.
Awesome. And one other thing that I will just kind of mention as I'm closing out before I turn it back over to Katie, it looks like there's a lot of interest in future research needs and direction. So Kurt, if you look at our Q&A and chat, I think you'll be really busy for the next several years. But one being, the totality of the US population, how many folks would be eligible for a produce prescription program? And I think that is a really great question. And another is just, thinking about future directions of produce prescriptions, medically tailored meals, on outcomes as well as healthcare costs. But I'm going to go ahead and turn us back over to Katie to help close us out. So thanks so much for that really great Q&A and for your wonderful presentations.
Wow. The chat is overwhelming. The questions were amazing. I'm sorry we didn't get to everything, but we will do our best to follow up with everybody and share the recording as some of you had asked. But please go ahead and visit fruitsandveggies.org for more information. We have a lot of research there as well as resources for you. Don't forget that September is National Fruits and Veggies Month. It's a great time to set up some maybe pilot programs or test some promotions and really try to elevate fruit and vegetable consumption to a national priority as we are all trying to rally the produce industry and everybody along the way to help consumers feel inspired that this can be easy and we can give them access and boost appeal to grow consumption. Next slide. Just so you all know, we do have all of our webinars, including this one, are available in our resource library indefinitely, and you will still be able to get continuing education credits for those. So there's a lot of great resources there, including another example of produce prescriptions that we talked about from the Center for Nutrition a few years ago. So make sure you visit that. And then I just, again, want to really thank Kurt and Kathy for their time today. Stephanie, thank you for bringing it all together. That was a lot of questions to manage, and I appreciate y'all. And so everybody have a healthy and happy day, and I hope that you find many occasions to have a plant. Thank you. Take care.